Thank you. Thanks so much for the opportunity this morning, Phil, and for your assistance in getting me online. It's taken a little bit of time. But today I'd like to share with you all our project on food refusal in prison healthcare. So my name is Liz Barnacle. I'm currently the Interim Head of Safeguarding at Spectrum Community Health, and our organisation provides services within primary care, sexual health services, drug and alcohol services in prisons. I'm a mental health nurse by background, and having worked in secure units, personality disorder services and high secure prisons, I became a Queen's nurse in 2021 for my commitment to prison nursing and have a passion really for how we can safeguard some of the most vulnerable patients that we care for. So in the context of prison healthcare, food refusal poses a really unique challenge. And in this presentation, we explore some of the challenges really in managing those complex cases, the importance in the role of mental capacity, and that by fostering kind of a deeper understanding around the issues of food refusal, we aim to have safer and more positive outcomes for patients. So what factors lead to an individual commencing a food refusal? You might ask why people go on food refusal. Well, for us, it's essential to understand that each case is unique and the reasons for food refusal vary widely, really, among individuals. Some of the most common reasons for food refusal being a protest or a statement. Individuals in prison may use food refusal as a form of protest or statement about prison conditions, treatments, or other grievances. They may refuse food to draw attention to specific issues or injustices within the prison system. And this includes things such as wanting to be in a different prison, disagreeing with their prison sentence or their conviction, not having access to to healthcare or perceived treatments that they need, not having prescription medication, not being granted things like parole, or having their IEP incentives, earnings and privilege level being reviewed. Mental health issues. So individuals with mental health conditions such as depression, anxiety or eating disorders sometimes refuse food as a manifestation of their emotional struggles. And food refusal is often used as a way for some to regain control or to cope with those kind of emotional distress symptoms. In several cases that our teams have been involved with, individuals have had delusional beliefs around food, have developed psychosis, and for others, their diagnosis of dementia has sometimes impacted on their ability to eat or drink. Physical health problems, including medical conditions that affect appetite or digestion, can lead to food refusal. In some cases, individuals may have an undiagnosed or untreated condition that results in a loss of appetite. They might have dental issues that's impacting on their ability to eat. We've had some individuals that have been struggling with addiction-related issues and that may be experiencing withdrawal symptoms, which is impacting on their appetite. In certain situations, individuals may be coerced or threatened by others to refuse food, and this can often happen within the secure environment. In cases of bullying, extortion, or even gang-related activities within the prison. In some cases, individuals engage in a food refusal because of peer pressure or the influence of others. And this can often be related to group dynamics within the prison system. And we sometimes find cases where when one person refuses food, so does another, and another, and then another. Individuals with a history of trauma, abuse, or neglect may have complex relationships with food and eating. Some individuals refuse food due to dietary restrictions, religious or cultural reasons, or because of personal preference. They may have concerns about the quality or safety of food in prison, or due to what they perceive as a lack of access to food or limited funds to purchase their own food. And it's important really for us to approach each case of food refusal within our estates with real sensitivity and a trauma-informed multidisciplinary team approach. We can all play a crucial role in assessing and addressing the underlying causes of food refusal and provide appropriate support and intervention to affected individuals. So there's several challenges really in managing food refusal cases in prison. As I mentioned previously, it poses a unique challenge with several factors that require the teams to really consider. Firstly, we have a duty of care. So prisons have a legal and ethical duty to ensure the safety and well-being of all individuals in their care, including those who might refuse to comply with rules or instructions. So balancing an individual's right to refuse with their duty of care can be really complex. There's mental health considerations. So in some cases, we've had individuals in the prison who might well refuse rules or orders, but in combination with being on a food refusal, it's also been recognised that they have an underlying mental health issue, and that requires attention and treatment. So managing these cases often involves assessing whether the food refusal is as a result of a mental health condition and addressing that appropriately. It can sometimes lead on to security concerns, so food refusal cases can lead to disruption within the prison environment. Some people have been known to refuse food or fluid or trigger an admission to hospital. So staff must really carefully manage these situations to prevent harm to staff, the individual concerned who's on a food refusal, but also with consideration around how to manage cases sensitively with consideration for the protection of the public should the individual require admission to secondary care services. There are legal and human rights, so individuals in prison still retain certain legal and human rights, even while incarcerated, and staff must navigate these rights while also trying to maintain the order and security of the establishment. Food refusal cases can sometimes lead to legal challenges, making it essential that we consider all of those procedures and that they're managed appropriately. Effective communication with individuals who are refusing food can be difficult. Particularly if they're being uncooperative, agitated, or non-verbal. There can also be some challenges with partnership working with further support and advice and expertise and when that's required. And we sometimes require that from external sources. Each case of food refusal really is unique, and it might be influenced by factors such as the individual's history, the nature of their offence, any personal grievances or perceived injustices, and understanding the specific context around the food refusal case and addressing that appropriately is really crucial. Refusal cases of food can often escalate really quickly, and this can lead to confrontation, the use of force, or other disciplinary measures alongside managing a food refusal case. Staff must be trained to de-escalate these situations where possible and use force only as a last resort. And there's often many ethical dilemmas within the prison service, particularly when an individual's refusal often involves a matter of principle or a deeply held belief, and managing and balancing that respect for these principles alongside a prison route is also really challenging. So the food refusal policy. So here's a little bit of a story really behind the development of the food refusal policy in our project and the development of the toolkit. In June 2020, I was working in a high secure prison within the mental health team, and at the time we were 5 months into the pandemic. The team on site were managing a patient who'd commenced a food refusal, which then escalated to a fluid refusal too. The patient had established features of dissocial and paranoid personality disorder with increasing paranoid beliefs. He wanted to die and was refusing food and fluids, and he presented with the onset of paranoid psychosis in the context of an underlying personality disorder. He'd lost weight, he was dehydrated, and there were significant risks to health. He was refusing treatment for his disorder in custody, alongside any investigations or monitoring for his physical well-being. I was in regular contact with the safeguarding team at the time around concerns around how we managed his safety within the prison environment, and asked if I could develop a policy around the management of food refusal cases in prison. It was an emerging problem for our service and many other prisons. We had no guidance for supporting staff in managing these cases. The policy was developed, went out for consultation, and was approved to be rolled out across all of our secure sites. In 2021, our head of safeguarding at the time was then successful in funding a bid from NHS England relating to a quality improvement project around patient safety in prisons for individuals who engaged in food refusal behaviour, for which some it becomes a safeguarding concern. The initial stages of the project involved carrying out interviews with staff on site who'd experience in managing those cases of food refusal, and the toolkit was developed based on what staff told us that they wanted to support them in increasing their knowledge, awareness, and confidence in managing these cases. We had 3 key aims of the project. The first one was about identifying gaps in knowledge and patient safety risks that were a concern. This project was pioneering, and to our knowledge, there was no other research or other focused work within the UK which considers food refusal in prisons as a safeguarding issue, nor were there any other tools for staff to enable them to manage such cases. We believe that this lack of focus was because food refusal in prisons is a hidden issue, as often is prison healthcare as a whole. The prison population is an additionally vulnerable population and vulnerable group with a higher proportion of complex needs when compared to the general population. In 2021, it was clear that staff struggled with recognising these cases as a potential safety concern or a safeguarding issue. And there was a small number of cases which progressed significantly, one to the Court of Protection, and some where patients required urgent hospital admission. There were challenges around the use of mental capacity assessments. There was a lack of joined up working between partners, both internal and external to the prison setting. And incident reports provided us at the time with an estimate of the number of these cases, but at this point we were unsure if they were being recognised or actioned. Staff struggle to manage and understand refeeding syndrome, which is a potentially life-threatening condition when people who have taken a significantly reduced nutritional intake over a period of time then begin eating again. And the gap here was around staff knowledge and understanding of risk, processes, and the clinical management of refeeding. Secondly, we wanted to increase the skills and knowledge of our staff teams. So our safeguarding specialists within our team at the time developed some accompanying training to support staff with the delivery of our toolkit. And this has been presented across all of our secure services within Spectrum. It's led to an increase in knowledge, skills, and confidence in staff dealing with complex cases of food refusal. We've also provided consultation sessions to enable staff to discuss those complex cases that they're managing on sites. Prior to the toolkit launch, we completed a case file audit of several food refusal cases to obtain a bit of a baseline really around our current practice and an understanding around the knowledge that our staff teams had in managing these cases. We intend to re-audit that this year. It's a piece of work that we're currently doing within our team to measure the impact of the toolkit and our training on our sites. The food refusal audit supported our previous observations in relation to the gap in knowledge and processes, and it's led to further work and re-evaluation around the mental capacity assessment and best interest process within our organisation. Safeguarding adult incident reporting has doubled within our secure services over the past 12 months. Most of these incidents are around self-neglect, which is largely as a result of the increase in known food refusal cases. We've also seen over a 100% increase in requests for the safeguarding team to participate in MDT meetings in the past 12 months. This demonstrates really how staff are embracing our MDT model and seeking support and advice for complex cases when needed. Feedback tells us that this is due to the staff awareness in recognising and responding to food refusal as a safeguarding concern. And thirdly, we wanted safer outcomes for our vulnerable patients. Some examples included in this are how the toolkits contributed towards safer outcomes. So patients are now able to access information around the risks of refusing food or interventions associated with their food refusal. For example, physical health monitoring in a format that they can understand that enhances patients being able to make informed choices. We've also been able to ensure that patients are supported through staff completing more robust mental capacity assessments around decision making and enabling patients to access independent mental capacity advocates when needed to ensure that our actions are in the best interests of our patients. Risks for patients being promptly identified, assessed, monitored and reviewed in relation to their physical and psychological well-being, and an enhanced multidisciplinary team working approach, which has led on to shared decision-making, responsibility, action planning, and the escalation of cases which are potentially complex or require additional expertise or support, which is known to benefit patients across our services. Access to the pocket-sized toolkit and online PDF version has also saved time for a lot of our team. So some of the feedback from staff on site has been that they've been able to keep a copy in all of their clinic rooms, which has increased the ability to access this guidance. And I think our patients really are at the heart of what we do, and the toolkit's contributed towards creating a culture of safety through working together, shared responsibility, communication, and keeping the patient at the centre of what we're doing by making safeguarding personal. So you might ask, what's in our toolkit? Now I've told you about our project. Well, This is what the toolkit looks like, and this is a little bit on the screen, some of the guidance that supports staff in decision making and following that process. So you'll see briefly that we highlight what food refusal is and the risks of refusing food and fluid. We ask staff to consider how they can make safeguarding personal, how we can consider an individual's communication needs as part of our assessment process. We highlight why we should consider mental capacity and how to complete a mental capacity assessment, followed by the process for best interests if we find ourselves supporting and managing somebody that may lack capacity to make a decision. We reiterate guidance for staff completing physical observations for patients that refuse food or fluids, and highlight the risks of refeeding and how we can review the risk and support staff with that process. We focus on MDT working and how to structure an MDT, and we also highlight our organisation's escalation process and discuss the importance of documentation and care planning. So, wider impact of the project. So the food refusal project has gained momentum nationally and has been shared across a wide variety of networks. It's on Twitter, LinkedIn, and we've been contacted by several directors of nursing within ICBs with requests to use the toolkit alongside our training. We published in the British Journal of Nursing in April this year, which enabled us to share insights into the complex and hidden nature of food refusals in prison, with a link to the toolkit and why this can become a safeguarding concern. Following on from this, colleagues participated in a webinar interview, sparking further conversation and debate within the legal, nursing and medical world around patient safety in prison healthcare in general. Our team also shared our toolkit as part of a presentation to students across some universities, which has then triggered students expressing an interest in a career in prison nursing, which is great for us. And another additional impact that's provided us with is that we're seeing less reliance on legal teams and more streamlined care pathway processes, which avoids our patients being transferred back and forth from prison to hospital when a pathway may become unclear. We've shared our toolkit within Safeguarding Adults Board and health partnership groups. And the other thing that we recognise is that this toolkit is not just specific for use in our secure estates. We've identified that it provides a source of information and guidance for other settings within the community. Colleagues within care homes have used it for guidance around physical health monitoring for individuals whose food or fluid intake is reduced, with consideration around the refeeding process. Colleagues within supported living services have used it for guidance around best interest meetings. Hospital colleagues have used it for guidance around scheduling in an MDT for patients with complex physical or mental health needs. And colleagues within our hospice environments have used it for guidance around assessments of mental capacity assessments. Colleagues within other secure estates are using it to equip their staff teams with clear, accessible, and practical information in managing cases. And feedback from kind of internal and external partners highlights its value in managing other challenges in caring for vulnerable adults who may be experiencing self-neglect or who are unable to make a decision around decisions around care or treatment. What this has highlighted to us is that this guidance has been shared far and wide, and it's about thinking around a wider resource in terms of managing not just food refusal cases, but other concerns that we have when managing vulnerable populations. The guidance really is transferable, and fundamentally it's contributed towards safer outcomes for patients who not only refuse food, but who have also an added layer of complexity. So thank you for that whistle-stop tour around the food refusal case. It is available on our website, and I think it just really highlights that this isn't just about food refusal, it's also about complex cases, it's about mental capacity, it's about teamwork and MDT working. So thanks again, and feel free to have a look at the link on our website.